Ruth, while we are here in San Francisco for GI ASCO, there'll be data on the use of cabozantinib in regard to HCC. And the phase 3 trial looked at cabozantinib versus placebo in the second-line setting. Before I ask you about that study, though, my understanding is that cabozantinib is a c-Met inhibitor, but my understanding is that there was a negative trial on c-Met inhibitor with the tivantinib beforehand.
Yes, so there was so tivantinib is a little different from cabozantinib. It does have any off-target effect, and it was a very promising study. We had a lot of hope for that study, and it's the first study that actually select patient based on a biomarker c-Met level expression in patients' HCC tissue, but that study was negative. We believe that because the drug has two targets, and so I think that sort of make the data is hard to interpret. And so cabozantinib is a different drug compared to tivantinib. And the current positive data in the randomized phase 3 trial seems that will bring another second-line agent into the treatment of HCC, advanced stage HCC.
So, Catherine, back to you. That kind of notion that Ruth is bringing up in regard to the c-Met expression and the specificity of the tivantinib that played in that role. But as you know, and you are the expert in that, hepatocyte growth factor is the target for this c-Met, and if anything, of course, the liver is full of hepatocyte growth factor. The tivantinib study suggested that the only patients that should go on that study, if I recall, was 50% 3 to 4 plus expression. Is this really like the make it or break it point, or how much c-Met do you need in that liver per se?
I don't think we know the answer to that, honestly, and I think that's part of why the tivantinib study failed. And unfortunately, we've looked at a lot of different biomarkers on biopsies, testing for PD-L1 on biopsies, which didn't pan out for nivolumab response. So, c-Met didn't pan out for a tivantinib response. We've looked at EGFR, we've looked at FGF, we've looked at HGF, and really none of these biomarkers yet have panned out. And I think that part of the reason is because HCC is a really heterogeneous cancer. Even within one tumor or within one patient, there can be really multiple different factors affecting the growth of it.
I totally agree. And if anything, I'm honored now that the meeting has completed is to tell you about the cabozantinib study that I presented, where the cabozantinib arm showed a median survival of 10.2 months. And in addition to that, the placebo arm had a median survival of about 8 months. And if anything, the study was statistically positive in regard to the outcome. And of course, it shows that benefit. If anything, I comment on what Catherine said, and I totally agree, because when we designed the study to begin with, we specifically avoided that selectivity of the patient with c-Met expression, because you're right, we don't know how much. If anything, really, we kind of, probably the same logic we'll use in regard to hormonal therapy for pancreatic cancer, or I correct myself, for breast cancer, because it doesn't matter how much hormone expression, but you'll end up with the application of hormonal therapy, despite even if it was a whiff of hormonal therapy per se. So that's really one of the reasons why the tivantinib story was really looked at a little different from the cabozantinib story per se. But to go back to even more into that multivariant choices of therapy, we spoke already about sorafenib, we spoke about regorafenib, we spoke about nivolumab, then we brought up lenvatinib, we just brought up cabozantinib, but also, Anthony already mentioned, and I think there's data also that was reported at that meeting in regard to the Keynote 224 of pembrolizumab. Can you tell us more about that?
Right. So Keynote 224 brings us some phase 2 data about the activity of pembrolizumab in patients who were previously treated for advanced hepatocellular carcinoma. I think the study had slightly over 100 patients. And the punchline really is that we see a response rate of 16%, which is certainly consistent with what we've seen in the same range what we've seen with nivolumab. And the toxicity profile also seems to be consistent with the profile of pembrolizumab or checkpoint inhibitors in general in other tumor types. So it provides more confidence in the whole activity of checkpoint inhibitors in this disease.
Yeah, no, it's fascinating. If anything, what we just heard about is multiple therapies, and no question, the key concern or the key question that we all have is how can we ultimately decide which therapy to use? And I think we had already some suggestions, but just to kind of relay them, we have the number one question is the TKIs versus the checkpoint inhibitors, and which role each one is going to play, being first or second line. Number two is we heard very clearly from Catherine that not necessarily every patient will be eligible for the checkpoint inhibitors. They could be very much not necessarily the right patients for the checkpoint inhibitors. And then, of course, if we are to talk into the TKI component of the discussion, is it sorafenib followed by Rigo? Is it lenvatinib maybe followed by cabozantinib? No question that many variables will come along here. Some of them, as Ruth suggested, might be directly related to the side effects per se, but maybe a deeper thinking that can come along, as we discussed, can come, for example, from the etiology, or the risk factor for developing the HCC, the ethnicity of the patient, Asia versus no Asia, the alpha-fetoprotein level, and of course also any potential indirectly or correlated markers, including, for example, the CMAT, even though we just agreed that the cabozantinib worked in everybody regardless of the CMAT expression per se.